Good evening, ladies and gentlemen. Welcome to Reference Point. I'm your host, Dave Coker-Hook, and joining me from Anchorage, Alaska today is Dr. Stephen Tower, MD, who is an orthopedic surgeon, and we're going to talk about what I think is a subject you're going to find very interesting, having to do with hip and shoulder replacements. Dr. Tower, welcome to Reference Point. Thank you for joining us down here.
It's a privilege to be included.
Well, thank you. And so in the little intro, I mentioned that you're an orthopedic surgeon. How long have you been practicing?
I've been in Anchorage in private practice for 26 years.
Oh, wow. Okay. So you've seen a lot of bones in your day, I guess.
Intact ones and broken ones and worn out ones. And
fantastic. Well, the subject matter to discuss today has to do with medical implants. I had seen a movie that you had a segment on, and the movie was called The Bleeding Edge, and it has to do with medical implants. And the specific area that tied into your practice has to do with hip and shoulder replacements and some of the challenges associated with the type of metal that is used in many of these types of things. So, what has metal always been used as part of the implant activity? Or I guess I should say, how long have we been using metal?
Well, I think there's reports going back into the 19th century of people trying to make a hip ball out of ivory or something like that, or even a bladder to resurface an arthritic joint. I don't believe any of those turned out particularly well. So arthroprosthetics, or joint replacement, has been successfully done for, close to 50 years.
Oh, wow. Okay.
And the successful early devices tended to be fairly simple, actually. Usually, in the case of the hip, there would be a ball made out of stainless steel, somewhat smaller than the original equipment, that was secured into the interior of the femur bone or the medullary canal with polymethyl methacrylate bone cement.
Bone cement?
Which we stole from the dentists.
Oh.
Dentists had been using PMMA for a long time. And then on the socket side, we would go in there and clean up the soft tissue in the socket and then cement in a plastic socket made out of polyethylene.
So you'd have a plastic socket and a metal ball would be the traditional way of approaching that?
That's what we've had the most experience with, and is still what is commonly used today. And we would call that, the nomenclature is to refer to that type of joint based on the material of the ball and the material of the socket. So that would be a metal on plastic hip.
Okay. And what type of metal were they generally using in those earlier days?
Well, we fairly early on, we did start with stainless steel.
Okay.
And based on my recent experience, I think maybe we should have stuck with stainless steel. Fairly soon after the first really successful hip came onto the market, which was called the Charnley low-friction arthroplasty, many others, Me Too's, came on the scene. Often, in retrospect, did not work out as well as the Charnley low-friction arthroplasty. But it was fairly early in the game, within the first 5 or 10 years, that other metals or metal alloys were used. And the most common one, other than stainless steel, was chrome-cobalt alloy, which is about 50% chrome and about 50% cobalt. Stainless steel is predominantly iron.
Right.
With a little bit of nickel in it.
Okay. And if I remember correctly from something that you had mentioned before, there have been there's different things, and I think I actually have a slide, slide number 1, that talks about and it has on it, there's metal on metal type of connections, and metal with plastic, and then there's ceramic and plastic. So they've used different kinds of material for purposes of the hip, or and I guess it can be used for the shoulder as well. Am I correct about that? Those different,
yeah, and again, I'd say our broadest experience has been using a metal ball rubbing on a plastic ball, and my interest has been in the complications specific to the use of chrome-cobalt in hip and shoulder replacement. And the scenario is it only really came to light about 10 years ago when this technology of using a chrome-cobalt ball rubbing on a chrome-cobalt socket or a metal-on-metal hip became very, very popular in the United States about a decade ago, and about 1 million patients received that type of implant. And it was touted to be optimal for high-demand individuals who wanted to resume rigorous athletic activity. Not that we haven't had patients return to rigorous athletic activity with metal-on-plastic hips. Many patients have, and there'd always been the concern with that technology that returning to a high level of athletic activity might prematurely wear out the joint.
Yeah, okay, I can see how that could be. You would think that might be possible, especially with the metal and the plastic, that the plastic might not be as durable as the metal component.
Well, about 10 years ago, when this all occurred, and what we knew about joint replacement, being about 40 years into the joint replacement experience, was that the best designs of metal-on-plastic hips would eventually show wear of the plastic part, usually not occurring in a significant fashion until more than 10 years after implantation. But that plastic wear, potentially people could wear through the plastic, but more commonly, the material produced by the wear, you got these little particles of polyethylene, which the body could react to, causing bone absorption. And the more common thing we saw was an eventual loosening of the parts and pieces, which had been secured into the bone with cement.
Oh, okay.
And we learned that was actually the body's reaction to the plastic debris. What I don't believe has ever been reported is that plastic debris ever making people systemically toxic.
Right. But you've seen that with the chrome-cobalt implants, is that right?
That's correct. And it's not something that I'm aware was ever reported with stainless steel, but with stainless steel, we were articulating a stainless steel ball against plastic, and stainless steel is much harder than plastic, so not likely to produce much wear of the metal.
Right.
Whereas with this metal-on-metal hip application, chrome-cobalt ball and a chrome-cobalt socket of equal hardness were articulating. And the theory was there'd be this fluid film lubrication between the parts, and there would not be appreciable wear.
Right.
Unfortunately, I think we know now that fluid film lubrication only really occurs in the laboratory in a steady state condition and doesn't occur in people.
So what would that fluid have come from? Would that have been just natural body fluids?
Yeah, joints normally have a small amount of synovial fluid, which is just a filtrate of blood, really. it's got a little bit of, it's got some proteins in it and some glycoproteins in it, which make it a little bit slippery.
Okay.
But it's not terribly different than water, so it's not like it's not like the oil in your car or anything like that you would expect would be highly effective at lubricating
as a lubricant. Right.
a metal on metal bearing.
Right. So let's talk a little bit about what you have discovered with respect to the challenge of the chrome-cobalt implants. Whether it be metal on metal or metal on plastic, it's the chrome-cobalt that seems to have been, based on your research, has created some problems for people. And I'd like to talk about that a little bit. And there, you had mentioned, there's one of the, you had been kind enough to send me some information and some slides, and there's one of them that has an inventory of symptoms. I think it's our slide number 2, that were things that you had seen in patients who have had this type of chrome-cobalt implant, and they were just a variety of things. Forgetfulness, fatigue. What's referred to as executive dysfunction, sleep disorders, just a whole slew of not so cool things that seem to be happening to people. And you sort of pulled the string and kind of figured out that a lot of this had to do with some toxicity based on leaching of the cobalt into the body. Is that that's my understanding, right?
Yeah, and there's a personal story here. At age 50, I personally needed a hip replacement. And at that point, I'd been a practicing orthopedic surgeon, I guess, for about 15 years with an interest in joint replacement. And I was the first surgeon in Alaska with an interest in revision joint replacement. And I'd also had an active research association with Dartmouth Biomedical Engineering Center. So I knew a fair amount about the concerns about the various materials. And I just, with Dartmouth, published a paper about catastrophic early failure of plastic hip liners when the material was made particularly thin after they had modified the plastic with radiation and heat to cross-link the material. And I was at that time still somewhat of an endurance cyclist doing these wilderness races, and the last thing I wanted to occur to me was to be stuck in some trail somewhere with a dislocated hip replacement. So
yeah, right.
So this metal on metal concept with a larger head, which was touted to be more stable, was attractive to me, particularly with my own work with Dartmouth, that it indicated that if you tried to get that done with a metal on plastic combination, that the plastic might be too thin and you might have a catastrophic failure of the plastic liner. So based on that and the popularity that the metal on metals were receiving at that time, and they very heavily promoted at orthopedic meetings as being the solution for younger active patients such as myself.
Sure. I mean, new technologies, often that's the case. It's like this is going to be the solution for all kinds of problems.
So the bottom line is I signed up for one, and I turned out to be the proverbial canary in the mine for systemic cobalt poisoning. I thought I did great. I was only in the hospital one night, and 6 weeks later I did a double century bike race, and I thought it was off to the races, and this was a great decision. Then at about a year, the hip started to hurt again. And that was a very unusual occurrence in my experience with metal on plastic joints. And a lot of the foundational research that supported the metal on metals had used the tool of checking the cobalt concentration in blood and urine as a marker for whether or not there was excessive wear occurring at the articulation. So I started checking my levels of cobalt in blood and urine, and they were off the charts. They were a couple orders of magnitude greater than what had been mentioned in the literature.
Now, cobalt is an element that it naturally does occur in the body, but only in very small amounts. Is that right?
That's correct. If you incinerate at death a full-grown man weighing 250 pounds, his entire body content of cobalt will be about 1 milligram.
Oh.
So it is present in the body. It's part of vitamin B12, but we're not designed to handle more than a minute amount.
Yeah, I guess.
And what happened in my case was shortly after I started experiencing the hip pain, and at this point I'd been checking my cobalt levels and I was aware my levels were high. I started developing a slew of new medical issues, largely excitability, irritability. I was 52 at the time, and it was quite disturbing to myself and my family. I was also developing severe ringing in my ears, some degree of high-frequency deafness.
So these sort of symptomatic things that you are describing that occurred to you, oftentimes are things that I hear people talk about that they think that either they're getting old or they've had, maybe I've got some sort of I won't use, maybe dementia or something like that. There are these problems that happen to people, and it would seem to be like almost like a normal thing. I want to ask you about that, but before we do, I have something I want to mention to the audience. I want them to make sure, pay attention to what we're talking about, and if you have any questions about what the doctor and I are discussing, send those questions in to info@referencepointtv.com, and we'll make sure to get them answered, because we're starting to get into some really deep level things. Okay, so you had these types of symptomatic situations, and then what?
Well, and I think had I had the hip done when I was 70 rather than 50, I probably would have reached the same conclusion. But in my own mind anyway, I was a little bit young for these things to be happening. And again, my mood changes and my irritability, I'd experienced as described in the movie, psychologic decompensation, which temporarily disabled me at about 18 months after the hip was done. And I was kind of perseverating and insisting that I was being cobalt poisoned. And in the context of my unusual behavior, this was just felt to be delusional.
Yeah, right.
People have a midlife crisis and, get diagnosed with a mood disorder. They said, well, Steve, you need therapy and medications. And I wasn't, I was just kind of a voice crying out in the wilderness. It was very interesting to be suddenly placed in the patient role.
I'll bet, yeah. So it's sort of like completely flipping the scenario, yeah.
Well, yeah, my patients and my physicians, prevailed, and I said, well, okay, I guess maybe I'm just crazy. So the bottom line is, counseling and medications help settle the situation. I soldiered on for another year and a half, or actually another 2 years, actually. A year after that episode of the psychologic decompensation, I became profoundly depressed and had another period of partial disability, and again responded to counseling and medications. And then over a period of another year, fortunately, the hip became so painful that it was clear that the hip had to be redone. And I had imaging studies done of the hip that showed the soft tissues around the hip were being destroyed by something we call either an adverse reaction to metal debris, or also commonly known as pseudotumors.
So you say metal debris, that means some of the chrome-cobalt, either ball or socket, was starting to just, the abrasions were causing it to fray a little bit, to just shave off?
Yeah, again, I was very physically active. I was riding the bike many miles, putting that joint through a lot of cycles. And my particular device was the somewhat ill-starred DePuy ASR XL, which is the only one of its ilk that was formally recalled from the market. It did not got recalled shortly after I published my paper, which was my own case report and that of one of my patients that I put the same implant in. Both of us experienced the problems at the hip and the systemic toxicity. But had the hip not become so painful, requiring revision surgery, I mean, I was functioning. I wasn't functioning at the level I was accustomed to, but I wasn't dying rapidly either.
Right, but things had changed dramatically for you. You had mentioned in our conversation the other day that eventually you had found that some of these challenges were not just isolated to you, but with some other patients. And I think you mentioned that a colleague, you worked with a colleague to do some brain scans, and that we're able to demonstrate with very graphic visuals that there was some anomalous activity going on in terms of the cobalt toxicity?
Yeah, and that was a much later development. Again, my realization that I was actually poisoned by my DePuy ASR XL hip, I couldn't really believe that to be the case until the hip came out. And not only did my hip pain resolve, short of the 9 times that I dislocated my revision hip, as I didn't have any ligaments holding the hip back in after surgery, and it took some years for the hip to scar in and become stable. But as far as my neurologic problems and my psychologic health, I was like Lazarus. Within a period of a month after my revision surgery, I got my marbles back enough that I wrote up my own case report and that of one of my patients.
So does the body just eliminate the excess?
You pee it out.
Okay, so there isn't something that you have to do. It's a process. We've got less than 5 minutes left in our episode here, but I want to have the guys pull up that slide number 3. This is the one that shows the brain scans, and what fascinated me about this. And by the way, there's something on there too, and highlighted in red, that shows some of the challenges: short-term memory loss, motor speed disordered mood. But this is such a dramatic visual, and in terms of what, because these areas that show blue on the brain scan shouldn't be blue, should they?
Yeah, for those images that you're looking at, if somebody had a perfectly normal brain, you wouldn't see anything. It would all be black.
Right.
So the cooler colors like blue indicate areas of the brain that are not using glucose as quickly as they ought to. And this is a normalized study compared to age and gender matched normals. And we started doing these scans, to put the time frame in perspective. My psychologic decompensation from my cobalt toxicity was 10 years ago. And that issue, fortunately, basically completely resolved itself when I got rid of the cobalt. We've only had the brain imaging for the past 3.5 years, not because it's a new technology, just because I hadn't thought to use it to study my patients with these complaints.
Doc, what percentage of the implants would you say are chrome-cobalt?
Well, this is the unfortunate thing that we've learned over the past 3.5 years, although clearly the now disfavored metal-on-metal hips, which include hip resurfacings, are the highest risk devices, most of the shoulder and hip replacements done in the United States over the past 30 years have used a chrome-cobalt ball. And that can produce chrome-cobalt metallosis or chrome-cobalt debris from corrosion, not from wear between the very hard chrome-cobalt and the plastic socket, but because of corrosion between the chrome-cobalt ball and where it's connected to usually a titanium alloy stem. And my present study, over the past 3.5 years, we screened 170 patients. And the reason for me to screen a patient was any patient walking into my office with a hip or a shoulder replacement that had a chrome-cobalt part.
Right.
And again, this is most patients that have ever had a hip or shoulder done.
Got it.
And
we have less than a minute left in our episode here. I'm going to ask you if you wouldn't mind sticking around and having us dig into this a little bit more deeply and pick up pretty much of where we're leaving off here, because what I'm hearing, and I want to mention this to the folks who are watching, what I'm hearing is that the usage of chrome-cobalt as the alloy that's used in hip and shoulder replacements is something that's been prevalent for probably 15 to 20 years at least.
More like 30.
30 years. That there are some challenges with that because of the issues with toxicity, but it is remediated. It can be remediated by just replacing and allowing the body to allow that to get rid of that stuff. So if you wouldn't mind will you stick around for a little bit more conversation?
Oh, absolutely.
Okay, cool. So I got to let the folks know that we'll be back in a few minutes, folks, here. I appreciate your watching us at Reference Point, and we'll see you next time. Thanks.